Good morning, all. Welcome to the National Symposium on Glaucoma in the 81st AIOC conference at Kochi. So, I invite our chairperson for this National Glaucoma Symposium, Dr. Ramkrishnan sir, Dr. Chandrasekhar sir, Dr. Krishnada sir, Dr. Vijaya ma'am, Dr. Pandav sir, Dr. Varun Naik sir, and Dr. Manoj Singh sir. So, please come to the podium, sir. Morning, sir. So for this national symposium, we have each talk of 10 minutes and we have 25 minutes for the panel discussion. So we will take all the talks first, and at the end of all the talks, we'll take the panel discussion. So without wasting much time, the first talk is by Dr. Bhaskar Mani. He is going to talk on evolving paradigms in angle and anterior segment imaging.
Good morning, everyone. Esteemed chairpersons, organizers, the local organizing committee, and Amit for inviting me for this talk. Thank you. The topic is on evolving paradigms in angle and anterior segment imaging. Some of the patents of the devices are owned, so that is my financial interest. We'll start with the goniophotographic techniques that there are quite a number of them now available, and for easy portable um, you know uh, imaging of the angle, we have some of these goniopen, redcam, anterior segment alignment, nidec, and some of the high resolution versions are available with the Wi-Fi. So it's like a handheld systems that are coming up. So hopefully these will kind of help us document the angle better. And with the nidec, multiple images are taken and stitched together so that the gonioscopic view is also there. Of course, there are some disadvantages in terms of visible light, which can probably constrict the pupil. So coherent light is used in most of them to avoid such issues as well. Of course, moving on to the UBM, which is mostly used in angle closure eyes and mostly used in glaucomas. Some of the newer advances are in 3D UBMs, mostly in experimental stage. And in this particular version, they are able to actually get multiple sections of it. And with deep learning, they are able to isolate the ciliary processes as well. And this is one of the experiments which they have done post CPC showing ciliary processes shrinking in size as well. Hopefully, these kind of technologies will get better with the newer semiconductors and deep learning algorithms. That I think one more talk is going to be on that, and that will be useful in our clinical application. Coming to the ASOCT, now we have so many of these versions are available, angle to angle scans. Most of us piggyback on the cornea department because they use it most of the time. And some of these newer techniques we are using to demonstrate the iridotrabecular contact in some of the patients and to see postoperative outcomes. And some of the higher resolution versions are used in mixed procedures as well to see the position of the stent and other conditions. And some research is ongoing on the aqueous outflow as well. So we have so many of these, and I do not think there is anything in particular that we can choose, but it is good to know about these things. Mostly these are like 14 to 16 millimeter angle to angle scans that are available. You can see that the anterior spectral is Cassia 1, 2, and there are some newer systems like hyperparallel OCTs called Silite, MS49 ASOCT, and the Dream OCT from Aftercare, and Optopol, Optoview. All those OCTs are available, and we get a 360-degree view of this angle. And this is one such technology where the hyperparallel OCT is done, where the scanning is done across, and you can see a good unfast view also. Had the opportunity to test those two systems, and we'll be giving you some results on that. This is again the Dream OCT, where you also get an OCT angiography, and probably the superficial and deep layers are imaged in this and may be used in aqueous outflow imaging as well. This is one of the studies which we compared gonioscopy with the SSOCT system. The agreement seems to be good. And with the gonioscopy, the performance always is slightly lower because both are different technologies. And the hyperparallel OCT also had such good agreement. And subsequently, when we looked at both the hyperparallel, that is the Silite and the Cassia, both of them performed equally well compared to gonioscopy. And this Anterion Spectralis is exclusively an ASOCT platform, and that is separated from the Spectralis for the posterior segment, and mostly used by the corneal surgeons for various biometric parameters and all, but it gives good resolution images of the angle as well as the lens. It can be used for some of the documentations that we have. When we use certain quantitative and qualitative parameters together, that algorithm gives a better output for gonioscopic angle closure. And there are some deep learning technologies that are being used to actually enhance this output and try to make it automatic. But only thing is the cost factor. And if you are in an institute and if the corneal people are using such instruments, these algorithms may be coming handy. And there are some of these indices that are available, like the ITC contact index, which can be automated nowadays. This is from the Cassia, and this is from the Anterion platform. Anterion takes just 6 images, and those are high resolution images, and automatically you can get this kind of ITC indices. One of the advantages of some of these OCTs is that you can also get the biometric value, so you can get axial length. Probably in pediatric and childhood glaucomas, to follow up these patients, it will be useful once the children are at a certain stage of cooperation. This, I think, somebody else will be talking. This is one of the studies which we did where Cirrus and Visante OCT performed well with comparison to gonioscopy. Some of the recent applications that people are looking at is to look at the Schlems canal variations, and they could see that the absence of Schlems canal with the ASOCT in juvenile glaucomas, and also the membrane across the angle can be imaged. And some of the recent presentations in this conference also show that when you have such membranes and you treat with the SLT or other procedures, the interventions can be less effective. So these are some of the research applications from which we learn how to manage our patients as well. And we also see that in the Schlems canal there are variations, and we don't know whether that can actually tell us some prognostic factors that we need to see in future. Also, there are digital enhancement available, ultra high resolution. Basically, these are more for in favor of looking at the Schlems canal and the angle, where these new mixed procedures are coming up. As you can see that is a cross-sectional view of the Schlems canal that can be done with these images. These are ultra high resolution OCTs where 1 micron resolution is seen, more for corneal procedures, but we can also see some of these nice Schlems canal in these. And some of this in vivo catheter probe OCT imaging also is coming up. Hopefully that will give some insights into the basic nature of the Schlems canal and the collector channel flows. Coming to that, the aqueous outflow imaging paradigms are evolving actually. So looking at the aqueous vein and episcleral vein, and this is looking at the transscleral aqueous outflow post-ciliary plasty. You can see that with the high resolution ASOCT, some pockets of fluid are formed in the sclera to show that there is a transscleral aqueous pathway. Conventional pathways are being explored with intraoperatively using indocyanine green, seeing here a nice anatomy of the collector channels, etc. This is one of the hemoglobin video imaging. I found it to be interesting. It's just a photographic technique with a special filter, and you can see these aqueous veins where there is clear column in between the blood vessels, and they're able to actually quantify that also. This could be useful. They have done some work on use of rho kinase inhibitors, and also with mixed devices, seeing the aqueous outflow. This will probably tell us how these mixed devices work and whether they will stand the test of time or not in future. Some of the vasculature patterns are being explored also with the OCT angiography in research applications to look at superficial and deep layers like this. And they are able to tell whether the medications or the devices can increase the outflow or even in trabeculectomies. Of course, we know that blebs are being evaluated with these devices, and the vasculature also shows that post trab the vasculature changes with time. And I'll just quickly go through this. At 1 month, the vasculature seems to be very high, and then it starts dropping. This kind of experiments will tell us when to intervene with medications, of course. And last, the photoacoustic imaging, where the ultrasound and the OCT advantages are used together in looking at various vasculature as well. We don't know yet whether this gives more advantages than the OCT or not. And of course, the tube's position, patency, and with time, what happens to the tube, whether it comes forward and affecting the cornea, intervening at the right time. All those things are some of the applications, of course. Some of the questions have also been looked at with these ASOCT. And recently with the KDB goniotomy, you can see this kind of wedge, and then slowly it starts becoming, flat, getting scarred. We need to see whether this has any prognostic indication as well. So ASOCT is mostly a research tool, but it has certain advantages. The multimodal OCT platforms offer a wide range of applications in anti-segment and angle evaluation. Ultra-high resolution, software enhancement, and volume rendering enable newer research opportunities. Clinical applications are evolving, especially with the mixed paradigms, and more research is needed to bring it to fruition. Thank you for your attention.
Thank you, Doctor. Thank you, Dr. Bhaskar. Our next talk will be by Dr. Satyam Parthasadi. He is going to talk on standard automated perimeter and virtual perimeter. Where do they stand today?
Thank you. I'll just briefly give you an overview of the old ones and the new ones, then just asking you to decide. So I'll just talk about the two old ones, that is the octopus and the Zeiss. What are the new things that is interesting in that? When you're looking at the octopus, you have these all the softwares. If you can just access it in your desktop, then you can see these things. This is called as the ONH projection analysis. It is the structural change what you see in the disk that can be seen in the octopus perimetry. And of course, we all see the posterior polar analysis. Similarly, we can see in the octopus perimetry also that is available as the macular map. Then you have the serial analysis. I'm not sure how good it is in the Humphreys, but the serial analysis in the octopus gives you an overview of whatever the fields has been done, what kind of fields has been done. Everything is in detail, so that we can just have a quick look at the serial analysis and you can come to some conclusion in that. And of course, it gives you a very detailed analysis of the progression, including the polar and the cluster analysis, which gives you a good clue of where exact locations of the progression is happening. Say, for example, in the central 10 degrees, either in the upper half or the lower half, then we can, take the treatment accordingly. And if you have just done a 30 degrees, or say, for example, you have done a G program, then you can just convert that to a 10-2 program within the same thing. You don't have to really do one more 10-2 program. And all the points are being taken. You can see here, this is the 10-2 and this is the 30-2. Same thing, you can just convert and then take a look at it. Then, of course, we all know that many of the glaucoma patients, they don't come for a checkup because they have a binocular summation. That's why they don't have much of a visual field effects. So if you can see that in the perimetry also, this is the summation. You can see how nicely this is the reason why the patient is probably not coming to us. But of course, they have their own many reasons. But the binocular summation gives us an understanding how the patient is seeing. Looking at the Humphrey Field Analyzer 3, so we know that the Humphrey has been there for many, many years since 1971. 2018, they have the upgrade on these parameters like a CETA faster, and 24-2 C program is the newer addition they have, and the mixed GPA, CETA GPA program gives a complete patient test history for the GPA reports. Then the data synchronization and the review software, they have the automated patient alignment. You can see here, this is a CETA program, faster program, which seems to be even more faster than what it used to be. It just does the test within the 2 minutes time, and it is considered to be the same as the other programs as well. The other thing which they have incorporated is the automated patient alignment program, which has already been there in the octopus for many years, but they have also incorporated so that the patient is getting misaligned and then it automatically gets aligned. So you can see here. So that is one of the improvements that they have done. And of course, you have the interactive guided progression analysis in the workplace. You can see that how nicely it has been given the GPA progression analysis. But all these things, if you can really access the software than just taking the printout, you will be able to understand this much better than just taking the printouts and seeing things. So this is the one which is available in the Humphrey. This is the synchronization and integration. And of course, reviewing the reports in your desktop with other, like OCT also have done, everything can be integrated and you can see that. So coming to the other perimeters, like this is one which you can do it in your iPad. This is the Melbourne Rapid Field Analysis Automated Perimetry. It is something similar to the reports are similar to our Humphreys. So it is a portable device which is done in the iPad. The clinical validation shows that it is comparable to the Humphrey field analyzer. They have the reliability indices, progression analysis after 5 tests. And it is user-friendly, multilingual, there's a screening support, everything is there. And this is how the test is, what the patient is seeing. Everywhere it goes, they have to just touch it. When they see the dots, that's how the test is being done. It's not that difficult for the patient because many of them are used to the iPads. And this is how the report appears to be. On your right hand side, you can see the reports, which is similar to the HFA reporting, but it is little different than HFA, but they say that it is similar to the diagnostic ability seems to be similar to the HFA, and it is also used in the neurological fields, macular diseases, and the diabetes also. It is pretty useful. And looking at the AVA, that is Advanced Field Analyzer, developed by ELISA Technology. So it is a head mount, especially when the COVID time. This was one of the popular devices that many of the patients could be used and tested. And it is very comfortable to use it because when you are wearing the mask, we know that there have been many papers have been published on wearing the mask and doing the test is not that good. So you can lie down, patient can be sitting in the OPD area, everything can be comfortably done. The patient can easily do the test because the both eyes are open in this. So what the patient sees the 4 dots, they say it is more accurate. It is something similar to the HFA patterns and can be used. So the advantage they say is it is obviously it is much cheaper. The testing time is quicker and it is quite comparable with the Humphreys. And the similar strategies are also available: 24-2, 30-2, and 10-2. And this is this is the components of the AVA component. The other one, the last one is something called as the Alpha Leas technology. This is one of the Indian companies. These are the parts of the device. It is something same as, but it has been accessed in your mobile phone to start on the device. Same way, it is all virtual perimeters. I think LBP also has one virtual perimetry, and there's one more company from San Francisco. All of them have similar pattern. This is color coded actually. And there are many versions are available in this. The recent version is called as the Intelligent Vision Analyzer. So the advantage of the visual perimetry is the patients are more comfortable. I have done it for myself than doing it on the Octopus or the Humphreys. It is much more comfortable. Both eyes are open, but then it has its own limitations in comparison to our existing perimetry, which I've shown you some of the advantages of what our old perimetries are already currently doing it. Thank you.
Thank you, sir. So we'll have our next talk by Dr. Susmita Kaushik. She'll be talking on application of newer glaucoma trials in our clinical practice.
Good morning, and at the outset, thank you for the opportunity to present this. So, newer glaucoma trials is something like landmark trials are something like an alphabet soup. And we have all of these which have been done for glaucoma. The research questions for most of these trials, surprisingly, was initially, should we reduce the IOP? So the ocular hypertensive treatment study, the CNTGS, the early manifest glaucoma trial, the AGIS, and the CIGTS actually answered the question as to should you reduce the IOP, and if so, in whom and in which stage. And I think we are done with that. So I'm not going to touch upon these because these trials are done and over with, and across the spectrum of glaucoma, we now understand lowering the intraocular pressure is beneficial. So the next set of the alphabet soup was how should we reduce the IOP? And then is the surgery, then which surgery? So which surgery was answered by TVT, the trap versus tube for already done surgical patients, and the primary TVT, which was done for patients who were treatment naive. If you wanted to put in a tube, which tube? So it was whether it's a bar welt or whether it's an AGV. If it was laser, is it good enough? Should we be doing SLT? So the light trial did that. Is cataract surgery beneficial for glaucoma? The Eagle study did that. And for the MIGS, the validated study that we have is the Hydrus 2, which we don't have in India, so we'll talk about that later. So the outline in the next couple of minutes, we'll look at the second part, which is newer. Which surgery? The TVT or primary TVT. Which GDD? The Ahmed versus Barwelt or the Ahmed Barwelt comparison. So there are two large trials comparing the two. For MIGS, there was the Hydrus 2, which had happened. Laser, the light trial has undergone a 5-year follow-up recently, so we look at that. And whether or not cataract surgery should be done or early glaucoma surgery is beneficial was looked at by the Eagle. So let's do the TVT first. The trabeculectomy versus tube study. So this question was always there that somebody with failed glaucoma surgery or previous cataract surgery, should you do a trab or should you do a tube? This was a multicentric randomized controlled trial with uncontrolled glaucoma pressures between 18 to 40 millimeters on maximum tolerated medical therapy. And these patients were randomized to a trab with MMC or a Barwell glaucoma implant. The outcome measures were the intraocular pressures, the visual acuity, fields, and the surgical complications. So, which has better treatment outcome at 5 years? So, they did publish 1 year, 3 year, and 5 year data, but let's look at 5 years. So, the key findings of this study was the failure rate with TRAB with MMC was about 46%, and with the tube, it was about 29.8%. And the reoperations for glaucoma were more in the TRAB, 29%, and less in the tube, 9%. So, that sort of seemed to suggest that you're much better off doing a tube than reattempting a trab in somebody who's already failed a trab. The visual loss had similar rates in both groups, and early post-op complications, the trabs had much more than the tube shunt, but the late complications were similar. The lesson for the clinician is that the mitomycin used was 0.04% for 4 minutes. Now that's a lot of MMC usually in the eye, and there's no procedure superior for treating a glaucoma, remember that. And the keep tubes in the armamentarium of surgical options and assess the patient's unique needs. But probably if you had reduced the time or the concentration of the MMC, those early complications of hypotony, etc., of the tubes might have not been there. And the factors for selecting a surgical procedure depends on the surgeon's skill and experience and the surgeon's planned surgical approach. So this was a very guarded outcome or conclusions of the 5-year data because they were a little guarded in saying that trabs were worse because the whole world didn't use these concentrations of trabeculectomy. So the next question was, okay, then what is the best procedure for a primary surgical approach? So multicentric trial compared the safety of tube and trab without previous ocular surgery, and 242 eyes again randomized. And the major difference here, and these were the same authors, was that they used MMC 0.04 for 2 minutes. Now that was what was more worldwide used. So they reduced that, and then let's see what happens. So the key findings, again, 5-year data. Tube shunt implantation and trab are both viable surgical options in glaucoma patients who had no previous surgery. So both procedures reduced IOP to the low teens. Mean IOPs were actually significantly lower with the trabs. So the primary TVT study told us that the trab resulted in a better IOP outcome if there was no prior ocular surgery, and early complications, which they said was after trap, but they were all self-limited, and serious complications producing vision loss were more frequently seen with the traps, but it wasn't statistically significant. Now, failure rates, reoperations were more in the tube, 37 versus 24%, and hypotony was more than in the trap, as expected, 10% versus 0, because you're ligating the bar well. So the overall success rate was same, and complete success rate was actually significantly higher in the trabs. So the factors for failure were a higher pre-op IOP and a lower pre-op IOP for more tubes. So if we chose a tube, now that's the next question, which one? So finally, if you've decided, okay, I'm going to do a tube in this patient. So there were two large clinical trials, the ABC, Ahmed-Barveld comparison, and the AVB, the Ahmed versus Barveld. So rather than go into that, there's a lovely publication of pooled data analysis from both these studies. So I'll just present that. 5 years later, these were the results. The Barveld implant had a low failure rate, a lower rate of glaucoma resurgery, better intraocular pressure, lesser medication, and a higher rate of hypotony. So that was a little bit of a caveat, but by and large, now this sort of stamped the fact that a non-valve device ultimately seemed to do better than the valve device. So the next is the light study. This is the laser in glaucoma and ocular hypertension. And this again was a multicentric RCT with 6 participating centers, which looked at newly diagnosed, non-treated POAG or ocular hypertension, and decision to treat was made by the consultant ophthalmologist. So that was allowed. The research question is, which is better as a first management? Is it SLT or medication? So the lessons were there's no significant difference in the health-related quality of life, but 74% of patients in SLT remain drop-free. And there was a lower cost incremental because you didn't have to buy medications after the initial costing. And SLT seemed to provide better diurnal in IOP stability with a continuous effect on the trabecular meshwork versus the episodic administration of medication. The next most controversial study, if I may say, is the effectiveness of angle closure glaucoma of lens extraction, the EAGLE study. The two major goals were in primary angle closure and high IOP or PACG with no cataract, is early lens extraction or laser iridotomy and medical care a better treatment choice? And is lens extraction or standard of care more cost effective in the medium term? So what was reported was 419 participants randomized, 208 had clear lens extraction and the others had standard care. 84% had complete data and 87% had IOP data. Now the IOP data was, it was 1.18 millimeters lower after clear lens extraction. And of course, it was more cost effective, which was irreversible loss of vision with 1 participant in clear lens extraction and in 3 who received standard of care. The points to ponder for us when we read this is there's missing information. So I would like to know what was the gonioscopy. There's missing in 247 of the 419 eyes. I don't even know what has happened. Has the angle opened up? Was there synechial closure? What was the problem? There's no information, and these are likely to be the ones presenting with glaucoma. PSC more than 30 millimeters of mercury is likely to be an appositional closure with a thick lens. There's no information on lens thickness. Maybe the lens vault was high enough to warrant a PAC, which means no glaucoma with 30 millimeters of mercury. Now, that's not a usual scenario in the clinical setting. And in these cases of standard of care could have been lens extraction anyway. So if you have a large lens vault and the disc is normal and the pressures are 30, probably it's reasonable to think of taking out that big lens in a small eye rather than doing anything else. And very early glaucoma, again, is not real world data. The strengths of this study, which is what they said in the complications, IOP lower, 1.1 millimeters at 3 years. How relevant is that clinically? Even though your stats say it's significant, how relevant is a 1.1 millimeters of mercury difference? Better quality of life? Of course, that's likely to be because of the intraocular lens. But your age is more than 50. So you're likely to have a nuclear sclerosis anyway. So are you just taking out a lenticular myopia? Is it more cost effective? It's only in a UK setting at the NHS where it's free. Is it cost effective because the surgery is free? Or would it be cost effective across the board? I'm not sure we would translate into all that. So in a nutshell, remember, can I take 30 seconds more? Yeah? Okay. So in a nutshell, remember, quality of life, they're non-Chinese. They favor standard of care. Chinese probably have smaller eyes and a larger lens thickness. So a non-Chinese quality of life favors standard of care. It's only the Chinese guys who had a better quality of life. If you had PAC, again, it favors standard of care. It's only PACG which favors lens extraction. And if it's unilateral, again, it favors standard of care. So it's not across the board. Intraocular pressure overall, though it favors the clear lens extraction, but in the non-Chinese, again, the favor was in terms of standard of care. So if you go into this, there are a lot of ifs and buts in this paper. MIGS is here to stay. Since it's not so common, I'll just say there's one ISTEN study group which has published 2 years data. 50% of patients with phaco alone versus 61% of patients in the combined group had a IOP lowering, which was the target. Complications, of course, with the phaco was corneal edema, anterior chamber inflammation, and macular edema, and a 3% rate of stent malpositioning and a 1% rate of stent removal. So this was the ISTEN study group, but these are just 1 or 2 year data, and longer terms are here. I'm not going into hydrus because it's not available here as yet. When it comes, we'll probably look at it. To summarize, all trials have stringent inclusion criteria and defined outcomes. I don't know how much we can translate all these patients into the patients that we see. Statistical significance may not be clinically relevant, and the information provided by landmark trials needs to be used judiciously depending upon the needs and safety of the patient in front of you. Thank you.
Thank you, Dr. Sushmita ma'am. The next talk is by Dr. Ganesh Raman. He is going to talk on MIGS, the Indian's perspective in POAG and angle closure.
Thank you, Dr. Amit. At the outset, I'd like to thank Chairman AIOC 2023 for providing me this opportunity. I'm going to speak to you on the MIGS, the Indian's perspective in POAG and angle closure. At the outset, this article, the important article and a very inspiring article based on this, which I'm basing this talk on, is from Dr. Vanita Patakre's article, editorial in the IGO. People who are going to start MIGS or want to start MIGS, they can go through that article. Quite a nice article, very inspiring for people starting MIGS. So MIGS is actually minimally invasive glaucoma surgery, and the idea is to give minimal trauma to the conjunctiva, as much as possible spare the sclera as well, do a ab interno procedure so that it's a bleb independent procedure, very reduced surgical time combined with cataract surgery it is possible, and very rapid visual recovery, less post-operative
Ganesh,
visits.
your slides are not moving.
Can slides move?
Oh, slides are not moving.
Yeah, okay. And less post-operative, very high safety profile and cosmetically more acceptable. So what we have, if you have involved the conjunctiva, for example, some procedures which I'm going to talk about is which will involve the conjunctiva, also considered as MIGS, we can call them as MIGS plus. So MIGS, usually we address the trabecular meshwork, so you can stent it, you can dilate it, you can cut through it, you can strip it, you can wash it. If you put it in the suprachoroidal space, you have some devices for that. If you ablate the ciliary body, so you can call it cycloplasty photocoagulation. If you add, if you involve the conjunctiva, you could do, devices are available for that, known as the pressure flow and the Zen gel shunt. And if you want to do a bleb independent procedure, also addressing the Schlemm's canal, you can do a canaloplasty procedure. So we don't have alphabet soup, but we have a lot of spanners which can be thrown at glaucoma. These are all the devices which are there, right from the iStent, the hydrus, the trabectome, and the KDB dual blade, and CyPass, and iStent, and also the pressure flow. So the idea is to use the natural eye's natural pathway, outflow pathway for aqueous production and drainage, so as to have a which has been untapped surgically so far. It's more physiological than the conventional trabeculectomy which we are used to, or tube shunt devices. So indications include mild to moderate open angle glaucoma, primary or secondary. Patient on 2 or more glaucoma medication. The idea is to reduce the number of medications, and needs to be combined with cataract surgery many of the times. And if you have intolerance and or barriers for usage of anti-glaucoma medications like allergies and non-availability of medication, then you could opt for MIGS. So the main demerit is that the intraocular reduction is not comparable to conventional glaucoma surgery like trabeculectomy, but you have numerous advantages. The main ones are the complications associated with TRAB and GDD can be avoided. They are particularly suited to reduce medication and also avoid extensive incisional surgery and ability to follow it, offer it in early stage of the disease spectrum. And you also have better quality of life, early rehabilitation, spares the conjunctiva, so you have area for future surgery, bleb-dependent surgeries can be offered. Very cost-effective alternatives are now available in India compared to ones which are available outside. MIGs have entered in India a little late. So the number of procedure and type of device available in India are limited, but you have alternatives to them. For example, if you have take the Omni device, you have the GAT procedure. If you use the KTB dual blade, you have the bang procedure. If you have trabectome, you can use an endoscopic cyclophotocoagulation or micropulse, which is, of course, in this situation, this particular device cost is an issue. Endoscopic cyclophotocoagulation was the original mix, which was developed in 1990 and can be used in a variety of glaucomas, irrespective of angle status, and sometimes more useful in angle closure glaucoma because it updates the ciliary processes, deepens the chamber, and causes, it can be combined with cataract surgery also. And micropulse diode may also be useful in a similar fashion, which people are now exploring. iStent has come recently into India, which is by the Glaucos Corporation. And in India, the main issue is availability of specialized healthcare. And many patients present to us very late in the course of the disease. So that's one big limitation when we want to practice mixed procedure. And we have almost an equal number of incidents of angle closure compared to open angle. So all the mix are not applicable for angle closure disease. Cost is an issue. Skill set has to be enhanced, especially intraoperative gonioscopy. And you have to upgrade your equipment also. You should have a nice tiltable microscope. Maybe your OT table has to be changed too. And supplies and easy availability of devices should also be there. So the role of MIGS, you have better outcomes with increased safety and early rehabilitation. It is open procedures like TRAV will continue to be performed, and glaucoma surgeons will need to upscale the current practices and management of the disease. So some articles which have been published. So this is from the LV Prasad group by Rashmi Krishnamurthy. They have done KDB and they found that the number of medications and has been reduced significantly, as well as the intraocular pressure has reduced in about a short-term study actually. And two studies from Coimbatore, one from our center, one from the High Foundation. They have also found that intraocular pressure reduces significantly at the end of 1 year. This is from our center. We had a series of patients. We showed that even sometimes in advanced glaucoma also, we have a 12-month data. Some of the patients who present with advanced glaucoma, but not so much medicated, they also have a very good intraocular pressure control. And endocycloplasty versus phacotrap by Dr. Vanita Pathakre, they have significantly showed that the number of intraocular pressure, the number of anti-glaucoma medications has reduced, and the intraocular pressure in the phaco with ECPL is actually quite comparable to the phaco-trap group, with the advantage of not having the complications of the phaco-trap group. And coming to micropulse, the article from Dr. Sharmila from Arvind Madurai has shown you have almost 42% intraocular pressure reduction in primary cyclo micropulse compared to 37% intraocular pressure reduction in patients who have undergone a previous procedure. So I'll stop here. Thank you for a patient listening.
Thank you, Ganesh. So our next talk is by Dr. Siddharth Dikshit. He's going to speak on applications of AI in glaucoma screening and diagnosis.
Thank you so much, Dr. Amit, for this cool topic in this hot weather. I will be talking about artificial intelligence and its role in glaucoma screening and diagnosis. Now, if you start looking up literature on this, you will see 50 articles published this year, and you'll see 100 review articles published on the same topic. So there's so much literature, there's so much information coming in, which means there is something happening there. And there is something more bound to happen. But because there is so much to listen to, so much to see, it might be a muddle. What I will try to do during this talk is to unclutter what you are seeing, not hide behind numbers, but just present the crux of it and try to understand where we can be and what we need to do in order to catch this train before it goes ahead. Now, ideally, we would want an artificial intelligence software or machine or robot to take in all the printouts and just give us the results like a lab test will do. You have diabetes, you don't have diabetes. You have severe diabetes, or you have mild to moderate diabetes. Do everything for us. But are we there? Now, if you try to look at this fundus image, focusing very close to the fovea. Can anyone of us confidently say whether this is glaucoma or not? Now let us zoom out a little bit. Try to look at this again. Can we confidently say now that there is a glaucoma in this eye or not? Let me zoom out a little bit more. And once you look at this disc, look at this excavation, look at this nerve fiber layer defect inferiorly, and you zoom in again, that nerve fiber layer defect is visible. Now, what was not visible very clearly at the outset, once we start paying attention to it and we have more information, we can start seeing it. And it is not, sorry, I went in the wrong direction. And it is not only us. Look at this OCT GCIPL map, which has been seeing at it, looking at it, and presenting it for many, many years now. So sometimes what we see even on a disc photograph on retinal examination, it may not be enough, and there may be technology which may be superior to our own judgment, even if we are experienced examiners. This is an image of a relatively earlier glaucoma. Here, even if you look at the fundus image, that to a red-free image, it's very difficult to make out any difference, and we see technology does better here. So it is possible that if you apply the right technology, they might see more than what we are seeing. Let us look at some examples. Now, I don't want you to go through all these tables, and it is a torture for anyone who would want to sit here, but I would want you to just focus on these three columns. Now, if you look at these columns, what you can understand is that the artificial intelligence, when it looks at disk photos, they have sensitivity and specificity above 90% or very close to 90% in all the cases. This is really amazing. So if you present, say, a resident or a fellow with, say, 500 disc photographs, and if 250 are glaucoma and they pick up 225 and 230, you say very good. But we don't say that when we look at a artificial intelligence software. The area under the curve here is very, very important to look at. It basically means that 95% or more of the glaucomas are being picked up by these patients at a high specificity rate. Similar data on optical coherence tomography suggests a slightly variable, but still a good correlation, good sensitivity and specificity for picking up glaucoma with a significant accuracy. Accuracy ranges 90% or more. Specificity and in OCT is a problem that we know does exist. So the ASOCT, the AI for OCT also does not have a very good specificity because OCT itself does not have a very good specificity. And these are when they start looking at multiple modalities and not just one single printout. So if you start looking at disk parameters and visual fields, OCT and visual fields, you are likely to improve the accuracy. And we see here in some studies the accuracies are as good as is as good as 98%, and there is an improvement in sensitivity and specificity for most studies. Now, why is there such a huge variation between all of these? Because the software that each of these studies have is very different and indigenously developed. So if we say AI is good, we cannot infer that from multiple trials. We'll have to say that the AI developed by Kim et al. AI model developed by Kim et al. Seems to be very promising. And let us look at it, let us try more on this. What we also need to know is that when AI says that the patient has glaucoma, what will happen when you go from a study group to the population? So in typical study groups, you have a 50% prevalence of glaucoma. So for a AI test or machine learning model, which has sensitivity and specificity of 97, 98%, with a prevalence of glaucoma at 50%, if you change that prevalence to 4% without changing the population of 10,000, the sensitivity, the positive predictive value will drop to 50%. So even if the AI says with that lower prevalence that the patient has a disease, the positive predictive value drastically drops. And if you increase the population to 1 lakh, the positive predictive value comes to single digits. So that test is not yet done. We have to wait for these excellent machine learning models to go into the population and then show us what the result is. Now, is there a reason to be scared? Of all the multiple modalities that we see in glaucoma, we all have different capabilities of looking and picking up glaucoma findings from the disc. We have trust issues with OCT, but I'm quite sure the modality that we are most confident with is visual fields. Now, when you have compared artificial intelligence with visual fields in all manners, in all ways, whether it is picking up glaucoma, diagnosing, differentiating between the two, being more accurate, having higher sensitivity and specificity, or detecting progression earlier, the AI has performed better than glaucoma specialists. And if you look at this figure from a very recent article, now this is slightly confusing, but what I can tell you, the more the study goes towards the top left corner, the better it is. So it will have a very high sensitivity. That means it picks up all the glaucomas without a high false positive rate. And if you look at AI, it's a spread. So we can't say that all machine learning models, all AI models are excellent, but there are some which are very good, and there is reason to believe that there is something good that is going to happen. And this is very interesting. This is a device that we have worked with Dr. Ganesh and the group have worked with, and it shows that just a mobile phone photograph can help you pick up glaucoma, which is very much in correlation with what the clinician does. So if you see a lot of crowding near the central regression line in both these graphs, you will see that all the points that the machine has picked up, they are very close to the central line. So there is a good correlation for diagnosing for the assessment of cup disc ratio. And this is the device that I'm talking about. There is no financial interest with this company, but we have worked with it and it seems very, very promising. Where can we be? Can we go to a mall, buy a burger, and while that burger is getting ready, go to a kiosk, get a fundus photograph done, and be told whether you have glaucoma or not, whether you have diabetic retinopathy or not, whether you have ARMD or not, with a single click? I don't think that day is very far because there are huge commercial interests that are being involved. We cannot stop it from happening. So it is our responsibility to pick up the right players who will set up that kiosk in a mall close to your home. But that's not just it. Can you imagine a lot of us have vision centers in remote areas, and they typically go put in a vision chart in front of a patient and ask them to read a line. And they typically pick up cataracts or advanced glaucomas, advanced corneal pathologies. But instead of the torch, if they can shine a smartphone onto the patient's eye, and even if there is a false positive rate of 50%, have high sensitivity of picking up all the patients who have a significant ocular disease, we will be at such a huge advantage of accessing all the rural population in the entire country. Now, how do we reach there? Oh, just 30 seconds. So we have to be data ready. Why is the West climbed onto this bandwagon? Because they have collected all the data for their patients. And we have to be ready to collaborate. And as Shah Rukh Khan would like to say, open your arms. Otherwise, you will end up saying, kuch kuch hota hai, tum nahi samjhoge, Rahul. Thank you.
Thank you, Siddharth. So the last talk of our symposium is lifestyle modification in glaucoma as important as in cardiovascular disease or in diabetes mellitus. This is by Dr. Tanuj Dada, sir.
So a very good morning to all of you. No financial disclosures. So the basic purpose of this talk is to shift your focus from being an eye specialist and focusing on the eye to become a treating doctor who can help to improve the overall health and quality of life of both the patient and his family. So the first important question is that is there any utility of lifestyle interventions? And this is a very famous study from Archives of Internal Medicine. Healthy living is the best revenge. So if you ask patients to stop smoking, have a BMI less than 30, have a diet rich in fruits, vegetables, minus meat products, and exercise 3.5 hours per week, there is a 78% lower risk of developing chronic diseases like diabetes, heart attacks, strokes, and cancer. So this is not possible with any drug. Lifestyle intervention definitely has a huge impact on human health. And you can see this study on the effect of meditation in patients who have got a chronic cardiac disease. There is a 48% risk reduction in mortality that is not possible with any medicine. Coming to glaucoma patients, there is evidence to show that smoking raises intraocular pressure and exercise can prevent visual field progression. So these are two things you can counsel patients. What are the mechanisms that cause the glaucoma damage? So since my residency, we have learned there are so many mechanisms: hypoxia, mitochondrial dysfunction, neurotrophin decrease, glial cell inflammation, nitric oxide dysfunction, and of course senile aging. But currently we only measure and treat the intraocular pressure. The rest are all theoretical and we totally ignore. And is there a need for lifestyle interventions in glaucoma? In recent literature, you come across this well-controlled but progressing glaucoma patients, high incidence of depression in glaucoma patients, and now you have this concept of mental stress, both consequence and a cause of visual loss. So this is a new concept, but amazingly, in Sushruta Samhita, 3005 years, 100 years ago, these great Indian sages mentioned the causes of visual loss, including excessive anger, grief, and high stress. Imagine their wisdom. So once you diagnose a patient as having glaucoma, 80% of them have negative emotions, especially higher risk of anxiety and depression. And if they have anxiety, glaucoma patients show higher rate of retinal nerve fiber layer loss. Additionally, glaucoma patients have very poor psychosocial function, high anxiety, high depression, and a reduced confidence in the healthcare system. So definitely there is a need for us to focus on the psychological functioning and try to improve the quality of life of our glaucoma patients. And you all know chronic stress can lead to hypertension, but do you know that psychological stress can lead to elevation in intraocular pressure? And this is primarily related to increase in the stress hormone, that is cortisol. It's very important to understand that glaucoma patients are already high steroid responders due to abnormality in the receptor. So once they get a spike in endogenous cortisol due to stress, that can lead to definite increase in intraocular pressure, and this is a concept we have totally missed. What about normal pressure glaucoma? It has been widely published that patients of normal pressure glaucoma have an autonomic dysfunction which increases in response to stress. And this is very clinically significant because these patients have higher rate of progression on the visual field. But there is nothing we are doing about this. So how can meditation help? In the short term, you can see this study, 5 days of meditation, just 20 minutes, can lead to increase in parasympathetic activity and decrease the sympathetic activity because regulation of the autonomic system by the frontal cortex. And if you see the long-term effect of meditation on the human brain, you will see that meditators were on an average 7.5 years younger than control. So they published that this is beneficial for brain preservation, and this is a form of neuroprotection that has not been available till now. Coming to our work on the effect of meditation on glaucoma patients, so all these studies have been done with meditation focus on breath for 30 to 45 minutes. So in the first study, we were very surprised to see that there was a significant drop in intraocular pressure, about 25%. But the more important thing was the blood markers. You can see substantial reduction in the levels of cortisol, the inflammatory markers, and changes in gene expression that can be very beneficial for glaucoma patients. A recent study, we also did the diurnal variation, and we found it reduces diurnal variation in glaucoma patient in addition to absolute reduction in the intraocular pressure. And also we tried it as primary therapy in patients of ocular hypertension, and we found that they do not need therapy, and just by meditation you can lower the intraocular pressure, the diurnal variation, and this is directly correlated with the reduction in serum cortisol. Very interestingly, we found that there is a special instrument known as functional near infrared spectroscopy, and we found you can actually enhance the oxygenation of the human brain with meditation and upregulate brain-derived neurotrophic factor. And recently, we evaluated the occipital cortex after meditation, and you can see significant increase in oxygenation of the occipital cortex after 6 weeks of meditation therapy. This is a very important study that we published. So we asked patients to do meditation, and in those where IOP was not controlled, they were subject to trabeculectomy, and then we did trabecular meshwork gene expression. And what we found was significant upregulation of nitric oxide synthesis and melatonin. And this is one of the main factors of how meditation can lower IOP, because there is upregulation of nitric oxide, which increases trabecular outflow and causes decrease in intraocular pressure. And finally, something we totally neglect. What about the caregivers, the mothers of patients with blind glaucoma? And it has been found that meditation is very useful to alleviate the anxiety and depression in caregivers of patients with glaucoma. So with one intervention, you are tackling ischemia, reversing autonomic dysfunction, improving mitochondrial dysfunction, increasing neurotrophins to the human brain, reducing inflammation, upregulating nitric oxide, delaying senile neurodegeneration, in addition to lowering intraocular pressure, and this is free of cost. So meditation is actually a poly pill for glaucoma patients because it has multiple actions, and in addition it has impact on other systemic diseases that the patient has. So now you have understood meditation is helpful, but then why are we not doing it? And that is the second challenge, that knowing what matters is not what's the matter. Lifestyle has a very tremendous influence on the human body, but the main problem is getting the public to apply the knowledge, and that is where we come in to disseminate this knowledge and have a political will or a society's will. And finally, how will you measure your life? It's not that you treated patients and lowered their intraocular pressure, but you actually made them thrive and flourish. And for one moment, you leave science. When you ask the patient to practice half an hour of mental quiet, you are actually bringing him in contact with a higher intelligence that is much beyond science, and that can significantly impact the patient's quality of life. And as you come closer to the grave, you realize that there is a higher intelligence which is very beneficial for you in life. So that is in summary the effect of meditation on the human brain and how it can impact glaucoma patients. Thank you very much for your kind attention.
Thank you, Dr. Tanuj. Now the panel is open for discussion. So I think we'll come from behind. Sir Tanuj, sir, you gave a very nice talk on lifestyle modification. So I would like to ask the expert panel if two or three people can answer this or take up this. A lot of people, when we tell them that you have been diagnosed with glaucoma, people tell, sir, what are the things which can do by which we can reduce the glaucoma, prevent the progression of the glaucoma? So what lifestyle modification would you give? I mean, green leafy vegetables, exercise, healthy diet, that is routine for to prevent any disease. But what particular anything for glaucoma would you advocate to your patients? GC sir?
Well, I think this work by Tanuj and the talks that he has been given has always intrigued me, and I have also looked at literature that he pointed out from the chronic diseases, cardiology, and cerebrovascular accidents and things like that. So lifestyle modifications do benefit those diseases. Am I actively advocating any of those to my patients? Unfortunately, I'm not. The main questions that the patients have is what is that they should not do. And from that perspective, the only thing that comes up is the so-called water drinking that people do in the morning, and the Valsalva mania related thing, and the yoga postures related increase in intraocular pressure. Those are the things that we typically get into rather than what is beneficial. I think there is a role for getting into that discussion, which I have not been doing personally myself.
So usually when we look at diabetes, hypertensive, the physician always tell 35 to 45 minutes of brisk walk, good avoid smoking, alcohol. This is all the standard protocol given. So as we as a glaucoma specialist, I mean, how important is meditation, yoga in this? Because whatever studies sir also was telling, increase in oxygenation is going to reduce the oxidative, I mean, the damage to the nerve fiber cells. So would you, any of y'all, do you all really provocate that you all should do meditation or yoga?
I mean, it.
Take this.
Can you hear me? Okay.
Yeah.
It's always impressive to hear that, but as GC said, we don't advise that to the patient. Maybe we ourselves are, I don't do the meditation as much as Tanuj does it. Maybe that is the reason. But the only thing I tell patient is a healthy body will have healthy organs. Keep yourself fit. That's very important, because it is not just the glaucoma we are concerned when we see our patients. The second thing is diabetes, cardiovascular disease, that will have a negative effect on the treatment of glaucoma. So if I see somebody little overweight or not looking normal, I do tell them, try to control your habits and try to remain fit. Other than that, I don't advocate anything else.
Yeah, that's correct. Thank you, Dr. Sanat, for a wonderful talk. What normally in our in recent years, what I normally used to tell our patients, whenever they diagnose the glaucoma or even the ocular hypertension, you just talk to them. You just don't get to panic, and it's a controllable disease. Of course, you can control with medicine or surgery or whatever may be, but other things like pointed out by GJ and GC, we have to take care of other things also, just like smoking or consumption of alcohol, and of course other things. Nowadays we have started telling about the Valsalva, the Sirasasram, and the water drinking. Water drinking is a common practice in most of the places. Early morning they used to take about large quantity of water, so that also you have to avoid. And another thing I used to tell them is, see, to rule out obstructive sleep apnea. That also is one of the important things that causes progression of glaucoma. So if it is, I will use to them whether you are snoring or anybody is complaining of snoring, something like that. You have a sleepiness in the daytime. Then also I have to ask them to go for a pulmonary test and to go for CPAP or something like that. Yeah, yes. That's the thing I used to do in our routine
Anyone else
practice.
from the panel
Yeah,
for this
I
particular
think
topic?
when we most of us don't actually prescribe these things because like meditation or effects of meditation are still kind of abstract to us. But I think what Tanuj is doing does a great work because he's actually giving measurable values to what was an abstract thinking. So once those measurable values come to be, because in science we want something measurable, so until that happens we kind of don't accept it as into our practices. So I think once we have those those parameters defined and shown evidence and made them more objective, I'm sure over a period of time we are going to be a little more open to these ideas, and maybe we'll accept them. And some of these things are already becoming acceptable, like benefits of exercise and other things is now is kind of understood that they are helpful, and people do encourage that you do exercise on a regular basis, take care of a diet and other things which are a little more obvious to us. But I'm sure with time, I think some of the data which Tanuj has shown is going to help in this. So I think congratulations to Tanuj for that.
Coming to the
Just
talk
one thought,
on,
if I may add,
yeah.
one of the important things that Tanuj pointed out is stress as a reason for the deterioration of the disease, and the stress that we as doctors induce in patients in our quest for early diagnosis and the latest technology that is to be used. I think the fundamental thing to realize is that glaucoma is a blinding disease only when the diagnosis is late or the disease is neglected. Patients who present with an early disease which cannot be picked up by the technologies that we are using, and start treating them and tell them that this is a blinding disease, and equate the red disease on the OCT imaging and say that you're going to go blind in 2 years. I think how can we be supportive by looking at not only but the stage of the disease as well as the possible rate of progression of the disease. I think that goes a long way in reducing the stress, at least in us,
Yeah.
in the doctors not causing the stress to the patient.
So as you said, the same thing in connection to that only the next topic, application of AI, what Siddharth was talking. So what Siddharth gave an example, we have the burger machine centers everywhere in the mall. We have this kiosk machine. Anybody can go and suppose he is diagnosed. The AI software says you are diagnosed with glaucoma, whether it's mild, moderate, whatever. Then we have Chat GPT again playing into the role. So won't it be more harmful? I mean, for the patients, I mean, the advantages and disadvantages of having AI or the softwares, research softwares which we are using. So I wanted to ask the panel, how really AI is going to change the way we are going to treat our glaucoma patients in the near future?
Can I just start with one statement? And it is my favorite thing I keep telling. When you look at the spectrum of glaucoma, everybody would have seen the Weinreb spectrum of glaucoma. And then the left down, you will see where there is without any changes in the eye, the diagnosis picked up. We are not looking at that. If you can pick up a small disc change and a small visual field change and diagnose glaucoma and treat that patient, the patient getting blind can be eliminated. So we are only looking at where there is a mild disease. We are not worried whether without any structural changes trying to diagnose it as a glaucoma. To do that stage pickup, probably a photograph may help. So if somebody gets it, maybe there is a need for the person to go back to ophthalmologist. There is a need for it. But at the same time, there is a possibility if there is a larger disc and larger cups, which can be physiological. So we have to be prepared for the false positive. It is not like diagnosing diabetic retinopathy or age-related macular degeneration. The confusion of glaucoma will persist in spite of the AI.
So anyone in the expert panel, you are using this software in your satellite centers for early diagnosis? Like Arvind, SN, PGI,
It's
LUPI?
whatever AI is available, it's, even our day-to-day practice, we have come across so many cases of overdiagnosis. Just with a single OCT or single visual field chart, the overdiagnosis is so high. And with AI alone, with this photograph alone or anything alone, we should not diagnose glaucoma. And also, don't kind the patient that you are having glaucoma in the initial, especially in early glaucoma. Don't tell the patient you are having glaucoma as pointed out to J and GC. No, that causes so much of stress, especially in juvenile open glaucoma or even with ocular hypertension, high myopia, where you have large disc and large cup. No? Some of the juniors, they will diagnose glaucoma, even treated as glaucoma. And patients are using unnecessarily drops for many years. So such things are happening in this. So that's why AI is a place, but AI alone is not this one. We have to do a comprehensive, a thorough evaluation of everything. Then only we have to coin the patient that patient is having glaucoma. Then only we have to start, because it's not an overnight disease. It is such a very, very chronic, progressive disease. So patient will not go blind if you don't treat them for 6 months or even for 1 year. Wait for the changes.
Manoj, sir.
Actually, I was talking the same thing yesterday in another session, that we should make technology our slave and not become the slave of technology. And what we need to use our diagnostic modalities, including AI, is to reduce the number of glaucoma suspects. See, we should be able to, in case there is something which is helping us to help to, say that this patient definitely has glaucoma or no glaucoma, then only it is a useful thing. Even OCT, I very strongly feel, is, unless it is very judiciously used, it is adding the burden of glaucoma suspects, and we are ever increasing the number of follow-ups, increasing psychological stress to these patients, and developing glaucoma which actually may not have developed if we had not given that stress to them. So we should not become slaves of investigations. And of course, it is very difficult. Tanuj is doing a great job. He's taking the industry head on, which I don't know. This is a billion-dollar industry, and how can we take this really head on and not do all these things?
So
Another
coming to
thing,
yeah.
Amit, is as Siddharth pointed out, Vision Center. We have about 120 Vision Centers, and in all the centers we have fundus camera. And whatever the patient referred as glaucoma, about less than half. Yeah, because the people posted there, they used to send fundus photos, and they will send as a glaucoma suspect or glaucoma something like that. Less than 40% are supposed to be glaucoma suspect or glaucoma. Other 60 are almost normal.
So that's what again in the satellite centers, like what AI will help us. So Dr. Satyan sir was talking about the virtual perimetry. So looking at the economics, the time, I think the virtual perimeters, the teleophthalmology along with AI, they might help us in creating, diagnosing accurately whether the patient has glaucoma or no by utilizing these techniques. So the next question was on the mixed talk. So looking at the way now mix India has picked up mixed procedures, especially the bank at KDB, and looking at the patient economy of our Indian patients, they are not really rich. And do you think that mixed procedure will take the first step over medications in our country because of the economic situation?
I have a comment to make. I don't know whether I'm correct or not. I don't think we can include the ciliary destructive procedures as
Yeah.
part of mix.
Yeah,
Okay, that is first thing. And second thing, at present point of time, if you look at any of these devices, and I'm not talking about the maybe GAT for the JOEG, but other devices, they're approved to be used along with the cataract surgery. So the question of using it as a primary mix in place of medication doesn't arise, as far as I'm concerned.
So what about anybody else? Any comments from the other panelists? Like, will it be a substitute or medications as a primary procedure? Nobody. Okay. So
Not
I think
substitute
considering
for
the
medication, but of course you can do it with early glaucoma with the cataract.
forget, right.
Yeah, not as a mix alone. That's what I.
Yeah,
I
and
feel.
there is a concept called a floor effect in terms of the outflow facility. If you have a advanced disease where the outflow facility has reached the floor effect, and mix are unlikely to help. So trying to scrape that trabecular meshwork using any of these devices, I'm not sure. So one has to be careful, apply the technology, use the device available to the advantage, but take a slow course, not to be too aggressive because there is a peer pressure for you to do the mix.
So coming to the talk of Dr. Sushmita Kaushik madam, she nicely has pointed out all the newer glaucoma trials. But the last slide we say what said, choose what is best for our patients from this all the trials. So the TVT showed 0.04% of mitomycin for 4 minutes. Anybody from the panel use that concentration for 4 minutes? 0.04% in Indian
Sushmita,
eyes.
if you see that TVT versus PTVT study, they started the PTVT study mainly to address the criticism raised with the TVT study. It is not to show anything. And it looks ridiculous now because when they're done the TVT study, there was a tremendous shift to do the tubes. And everybody started starting doing the tubes. Now they are saying that trabeculectomy is as good as the TVT. And we are becoming a laughing stock now.
So just to give a perspective, ma'am, it just happened that at the American Academy, when Stephen Gedde was presenting PTVT for the first time, I happened to be presenting Adi in the same session. And Stephen Gedde's opening slide was that since there has been so much of talk over the TVT study being 0.04 for 4 minutes, we are now embarking upon the primary TVT and reducing the concentration. And then let's see, and I think the AGV will still, the BGI will still score. But 5 years later, it didn't. The TRAB scored better, actually.
Most of us, you don't even use for 2 minutes.
Yeah. No, 2 minutes they must be using, ma'am. Maybe it's 0.02 for 2 minutes.
Yeah, 0.4
But theirs
for
was,
1 minute.
yeah, but theirs
1
was
minute.
0.04 for 2 minutes.
For some complicated glaucomas like uveitic and neovascular,
Yes.
we do use it for 4 minutes.
No, that's okay.
But
That
Not in primary. Yeah.
But the concentration,
Study will it be 0.04 for 4 minutes?
but
or
the
it will be
concentration
0.02
used,
for 4 minutes?
And also
0.4
they
for
have
4 minutes.
Oh, okay.
they have used the limbal-based flaps. The technology the technique has changed. With the fornix-based flap, we have shown the reduction in the complication.
Yes.
Same way, needling is considered as in resurgery. So that is a part of the trabeculectomy wound
Yes.
modulation.
And hypotony, early hypotony in the TVT study was a complication. And in the PTVT study, it was called early hypotony, but not complication. So all of that also. So that's why it's so important to go through it.
Anyway, the message I think is trabeculectomy still works. Please
Yeah.
don't think that you have to offer a tube as a primary procedure.
So the next
Or
question.
mix as a primary procedure.
Just one
Amit,
point
just
about
a
mitomycin.
clarification.
Just one point about mitomycin. I think the most important thing about mitomycin is small area application versus large area application. That I think is the most important thing. If you keep applying for a small area, then there's a time bomb that develops there. With the large area application, the trabeculectomy and mitomycin application has been extremely safe. The definition of failure in the TVT study, I had written a letter to the editor also. So the next surgery following TRAB is tube, and the next surgery following tube is TSCPC. So if that is the sequence that you have, and you're defining your failure very liberally, then you're prone to have more failures in the trap group than the tube group. Because you're interested in doing the tube. So the threshold for the next surgery will definitely be low. And who would want to do a TSCPC in a seeing eye if that is the next surgery?
So coming to the Eagle study, still a lot of misconceptions are there. Still people in our Indian ophthalmologists, they think lens extraction is one of the treatment for glaucoma. So what take-home message would you like to give in the Indian eyes? So what Madam stressed was quality of life in Chinese population is different, but for Indian eyes, what just out of Eagle study we should give everybody as a take-home message?
I think to
Anuj
step
has
back.
done the guidelines for AIOC angle closure.
Yeah.
So,
Madam, you are deferring the difficult question to me. So actually, there is no blanket statement you can make regarding this. It has to be case based, and the most important thing is the thickness of the lens and the lens wall. So if you have a patient, first always the YAG iridotomy should be done. After YAG iridotomy, if the pressure is not medically controlled, and if you have a lens which has got an increased thickness and an increased lens wall with a very shallow AC, then the surgeon can take a call on doing a primary lens extraction. But if there is an advanced glaucomatous optic neuropathy, then that should not be done. It has to be combined with a filtering procedure. So I think the Eagle study, you can't just directly correlate. Primary, you should do a iridotomy and then move on to the second stage treatment.
So the clear-cut
think even the
indication is if
lens
there's a thick lens and a high wall, then only we should go for a lens extraction.
I have an objection to even that. Even a thick lens and a lens vault does not mean that the patient is going to develop blinding glaucoma. Okay? These are only anatomical factors. You have to show that there is a significant oppositional closure which is resulting in raise in IOP, and that oppositional closure you can open up with indentation gonioscopy and not with any fancy imaging technologies that you're talking about, because none of them can do indentation. So the only benefit that you will get with a lens extraction is if there is oppositional closure of the angle that is resulting in raise in IOP that can be opened up by indentation or by pilocarpine, you can reduce the IOP, only then the lens extraction will be useful. Because if there are so many angle closure suspects and very short percentage of them are going to develop angle closure and angle closure glaucoma, and if you end up doing cataract surgery for all of them, based on your imaging technology and the lens vault and things like that, forgetting all the physiological factors that are required for causing the disease, then you're only increasing your practice of doing cataract surgery. If that's the goal, then there is no objection. You can justify.
No, is it lens?
Eagle study, one more major point in Eagle study is that gonioscopy that you pointed out. And the second thing is the sample size was calculated to show a pressure difference of 2 millimeters or more. They've got a pressure reduction of only 1.8. So from the study point of view, intention to treat analysis, it's a failure. You can't even bring it up in the result as a positive result. So too many lacunae in Eagle study.
No, in the scenario which you had mentioned, oppositional angle closure, did you mean clear lens extraction is not indicated, or is it the cataract extraction? If there is cataract, we still go ahead with cataract extraction.
If you want to remove cataract or clear lens, from the point of view of angle closure disease, Ravi Thomas's article in Perspectives, I think, clearly states this. The point that I'm making is that you have to show that there is an oppositional closure that is causing raise in IOP, and that oppositional closure can be treated by taking out the lens. Okay, if you don't even do indentation gonioscopy and know how much of it is oppositionally closed, how much of it is opening, what is your lens removal going to do? You are presuming that you are able to open up the angle by removing the lens. First, show me that it is closed and that is causing raised IOP. Only then the question of opening it up will come, no?
No, sir. What I'm trying to suggest is that after YAG iridotomy, if the pressure is not medically controlled, then what is your option? Would you do a lens extraction or would you do a trabeculectomy? There are only two options available, no third option. So what would you suggest?
So that like you said, depends upon the amount of damage and this thing. Even there, whether you do a trabeculectomy or whether you do a combined surgery if there is a significant cataract, or trabeculectomy if it's a clear lens, or do a clear lens extraction or just a cataract surgery, will still depend upon how much of angle you can open up with indentation and how much pressure control you can get by adding pilocarpine. So the functional trabecular meshwork that is getting occluded by the large volume of the lens that can be opened up once you take out the lens is the question. And the answer for that, I think, is indentation gonioscopy.
I think his question is, there is already a patient IOP is not getting controlled, and there is patent PI. And in such a situation where there is a high lens vault, do you do a trabeculectomy or the lens extraction? And
Lens
a small percentage, when the angle widens with the indentation, when there is high lens vault, offering a lens extraction may help in that patient. The reason is, people with the high lens vault, where the angle is very hard to open, if you do the trabeculectomy, the chances of getting a flat anterior chamber with the complications associated with the trabeculectomy is high. It is a very small group of people you will see, very, very small group of people. So that is the concern where the surgeon has to differentiate what is likely to patient.
I understand where you're coming from now. So I'll modify what I said, that the threshold for removing a cataract or a clear lens may be much higher in angle closure glaucoma than in open angle glaucoma in the context that we are talking about in the situation. But the point I made is that for you to believe that your lens extraction is going to be beneficial, you need to show that a significant amount of angle is oppositionally closed, that is opening upon indentation, and putting pilocarpine, because all these so-called plateau iris syndromes, okay, I have a lot of patients where you put them on timolol, then brimonidine, then netilonau, and then prostaglandin analogs. Pilocarpine, the pressure will come down, nothing else, the pressure will come down. So I think that is the point I'm making. The effect of pilocarpine is what will show you that your lens action is going to be beneficial.
I agree with you.
If you do a trabeculectomy and you get the problems into shallow chamber and lens extract, that's a different story altogether.
So coming to the virtual perimetry, looking at the cost factor, portability, solo practitioners, lot of people are going for virtual perimetry now. So among the panelists, what is your take? I mean, on the satellite centers, do you think this is a viable option? Do you think there are some negative pitfalls of using a virtual perimeter, or now all these perimeters have been validated in terms of when we compare with the Humphreys? So do you advocate that if budget is a constraint, we should go ahead with the virtual perimeters?
One-time diagnosis is fine, not for the
They,
follow-ups.
the softwares are coming up with even progression now in the
But
virtual
if they don't
perimeters.
have a significant amount of the data for the statistical analysis, do they have?
Yeah, Sachin sir, for you. Madam is asking, they don't have significant data to document on progression. I saw two companies, they had data for the progression also on virtual perimeter.
Yeah, they have 5 years data now on the progression, especially from the US based one of the companies. They don't want to name it yet. And I think Sirisha had one article on that actually, on their own perimetry for the progression analysis also. There's a significant data are available now. I think it is our feeling that still these virtual perimetries are not doing good, but it is definitely there. The patient comfort is much, much better than what we really do with our current perimetry. The sensitivity and specificity both are comparable with the Humphreys. That's what the data says. But I have very, very minimal kind of an experience with all the testing only. I haven't bought one yet, but it looks like quite promising in comparison to the Humphreys.
I heard a presentation from Mike Patella, the one who built the Humphrey perimeter, and his main point was that the incremental threshold values that you can get with the white light and that you can get with the screens that you have on the virtual perimeters are not comparable. So I will agree with what Vijay was saying, that for a one-time diagnosis, probably you're there, but for progression, I think it's going to be difficult.
There are other perimeters similar to the virtuals. They use a black background also, black and white. Some are using white and white. They all have the data now, but I haven't had any personal experience to see how the progression analysis is.
I think when we talk about data, we need to be very careful.
Yes, sir. Yes, sir.
And all the sensitivity specificities that Siddharth was showing, if you don't know what severity of disease that you're trying to see and pick up, and then you're seeing one side the classical normal disc and things like that, and if you compare them with actually so-called glaucoma suspects, most of the imaging technologies also don't do well. So what severity of disease that you're seeing and what's your control group is what is most important. So without that data, I think we just can't say that sensitivity, specificity, somebody gives a number, so I'm going to believe him.
Thank you,
sir.
sir.
It is not in that sense, I say. There
So-
are, when you are looking at the published articles, that's the one thing which you are saying is also right. Sensitivity and specificity is just not the
With
end
so
of the
many
story.
journals, such and anything can be published
It is
nowadays.
not
Excuse
the
me,
end
sir.
of the story, but
we
there are a
we
lot of...
conclude the session, sir. We are running late by about 2 minutes. Thank you, our esteemed panelists, and thank you, audience, and all the speakers for making this national symposium a great success. Thank you. I just invite all the panelists and the speaker for a group photograph, which will be done in less than 30 seconds.